Hi, my name is David Sallman from Moffitt Cancer Center in Tampa, Florida. It's really an honor to present on behalf of all my colleagues a really interesting poster on the evaluation of measurable residual disease, or MRD, in patients treated with CPX per standard. I think one big question in the field is, we know that survival has been improved in patients with CPX-351, but again, is this because of deeper and better responses or other factors, I think is a critical question. So I think to start, CPX-351 outcomes really in our treated patients at Moffitt are reflective of what happened in the phase 3 trial. In particular, patients that ultimately proceeded to stem cell transplantation have good outcomes. You can see, about 40–45% long-term survival in patients. Again, this is an elderly group of patients. We then want to kind of take it to some next steps. So I think interesting, if you look at patients that are potentially particularly sensitive, and NPM1 being a hot group, you can see essentially all but one patient did achieve a complete remission, and many of these were MRD negative by flow in that setting, and these patients had quite impressive outcomes. So then the big question, is MRD cleared or not from deep or error-corrected NGS? Again, we could comfortably call down to 0.1%. This was a collaboration with the Washington University with Dr. Megan Jacoby, who led the sequencing part of this project. So the long story is, it's actually very rare to clear mutations by CPX. So whereas MRD flow is about 60–70% in published studies, it was essentially only achieved in about 2 or 3 patients from that perspective, so about 13% were cleared. So I think what's notable in the patient for that did clear, obviously that patient is alive and essentially cured from that perspective, but obviously it's an N of 1. So I think this supports that novel combinations. Actually, Dr. Chan at this meeting is presenting CPX gemtuzumab. Can we deepen MRD and then further improve this? I think as far as how this could be utilized, when we look at the post-transplant setting, particularly if we look at relapse, so patients that cleared at their day plus 30 by error-corrected NGS, you could see we only had 1 patient relapse. And again, this is a very long-term mature follow-up from that perspective. So I think as far as predicting particularly relapse, the MRD post-allo assessment is most notable. I think in the pre-allo setting, again, I think this data really support that we need better potentially combinations to further deepen remissions, and potentially, again, brings into question, how do we use multimodality MRD approaches in the management of patients with leukemia? But thanks for listening.